Great. Let's get started. Let me first welcome you all. Thank you so much for joining this webinar. It's going to be a great one, very timely in these times. It continues to be surprisingly so. Before we get into that, let me request anybody who is in the audience and not speaking, please to turn off your audio as well as video, and only the panelists, please have your videos on. Uh, Welcome, everyone. Thank you for joining today's webinar. My name is Varun Rai. I'm a professor in the LBJ School of Public Affairs and in the Department of Mechanical Engineering at the University of Texas at Austin. Today's webinar, Policy, Equity, and COVID-19 from Modeling to Policymaking, will be presented by four terrific speakers who have done a lot of work, and you will hear about that in a moment. And they will cover COVID-19 modeling techniques and the importance of centering equity in policymaking, extremely important in today's time, especially what we have seen over the last year or so in a variety of arenas across the world. There will be four 10-minute presentations, and then we'll leave 10 or 15 minutes at the end for questions and answers. Along the discussion, please feel free to post your questions in the chat box. Our first presenter is Dr. Janwei Du. Janwei is a research associate in the Department of Integrative Biology at UT Austin. His research focuses on mathematical models of transmission dynamics, surveillance, and control of infectious diseases. His research on COVID-19 has covered everything from outbreaks in China to social distancing in Texas. He has done a lot of work, and we have interacted over the months with him, and it's been a fascinating journey just from our own academic scholarly work and how it is relevant in today's policymaking. And in fact, a lot of that is getting used in making decisions as we speak across all the levels. So with that introduction, I'll turn it over to you, Janwei.
Yes, thank you so much, Professor Varun, and thanks very much. Let me share my screen right now. Give me a moment. Okay. Oh, thank you. So, nice to meet you, everyone. And I'm Janwei, and in the work in the Austin, and as the research associate in the Department of Integrative Biology. And thanks so much for the invitation. And it's my quite honor to have this talk about the topic, about the COVID-19 and from the top down towards the agent-based modeling. And in this talk, I will introduce three parts. The first part is the background of why we do the epidemic modeling. The second is to compare the top-down modeling and the higher resolution in terms of design and their time complexity. And the third, I will give you a timeline of when and why we use each of them in different stage of the current COVID-19 pandemic studies. Okay, let me start. First at the background. Normally, when we do the epidemic modeling, we are always targeting some specific disease. For example, the COVID-19 pandemic, and this figure shows the number of the new cases in the United States is surging once again after the growth slowed down in the early summer. And the chart and the map offers a snapshot of the two earlier peak of the pandemic, as well as where cases count grows in recent weeks. And this case curves shows new daily cases reported, and this map shows the number of the new cases reported in each county. Okay, with such a background, as an epidemic modeler, we have quite a lot of questions to answer and explore. For example, in COVID, in such a big pandemic, so many questions waiting us to answer. For example, what's the risk? What's the infection risk? What's the impact? And who can be affected? And what are the public health consequences? And what can be done? And what can be done? And different researchers in different fields can answer different questions, and they can finally support the health policy for the government and make some reasonable, some economic, and some efficacy interventions applied in real world. And as a epidemic modeler, they may answer this question: what's the impact of some strategies, some interventions? Because for other fields, when we want to do something, we must make sure what's the result, what's the death, what's the hospitalization, what's the infection will be worthy for something. And for so here, mainly as agent-based model and the meta population model, the big model or fine model, we always focus on the impact if we do something for future, and what's the impact given we have did something before. Okay, and when we target epidemic modeling, we need to realize epidemic spreading across the different spatial scales. The epidemic disease is mostly transmitted within households and household-like settings. A decreasing proportion of the transmission events can take place at increasing spatial scales, and these events become essential for spreading the pandemic. And even if long-distance transmissions events are rare, but such a small numbers of such a long-distance connections are necessary to bridge any two regions in the worldwide. This is the one reason why early travel bans cannot stop the global spread of COVID-19, although they may have slowed down the pandemic. And in this spatial scale, we normally use two scales. For example, we normally use the mental population modeling when we would like to study the epidemic dynamics between countries, between cities, between regions. However, if we would like to focus on the city scale, we normally can build both on the agent scale by consider individuals in households and other scenarios, or build on the meta population scale by aggregating people, a small region as a whole. And when we do the top-down meta population modeling, we consider the country, the city, a big region as a whole, and connect it by the human flows. However, agent-based modeling has a much higher solution. It can character many features of epidemic spreading, for example, people's behavior changes and the viral load dynamics. But although it's good, but it needs many more dynamic informations, such as the household structure and the age group structures, even the contact patterns between two individuals in work, in school, and other social scenarios. So agent-based modeling also need much more time, computing resources. Normally, it takes hundreds and thousands times than the meta population modeling. And let's take an example. This is the China. Let's just take an example. This is the first in the 2009 and 2020, in the very early stage in the outbreak, when it's first reported. For example, it's first reported in the January 5, January 10, and some Chinese news began to say there is a new virus, and they don't know anything about that, but they just know there is a virus, and it began to spread in Wuhan. And that is the information in that period. So in this stage, the most important questions is what's the risk? Because when we start at the January 23, we would like to say how many people had been infected, and thus we should close the city or do something others. What's the risk? Is the most important in this period. So In that period, we first used the mental population, the top-down skill modeling to consider the to estimate the probability of the COVID-19 from the Wuhan to other Chinese cities before the quarantine. And if we, just based on top-down modeling, we could say around 130 cities are expected to have been infected, and we also estimate the speed with which these control measures contain the transmission in 58 Chinese cities. And we find after this study, we find if the government can 1 day delay of the social distance can result the outbreak disappeared of 2.4 days. This is the early study. And then the COVID-19 pandemic begins to rise in the US since the March 2020. And then we built a national influenza surveillance. We have ever built a national influenza surveillance and control model for CDC. And it's well built since last year. And then we began to apply the data, the model, and that platform and the target for the COVID-19. Based on this framework, we project the COVID-19 hospitalizations in 22 Texas cities from since the April to right now, and coupled with different degrees of social distance and their impact or something like that. And that is for the top skill modeling. However, top skill modeling always have questions. It can only answer the big level, for example, the city level or the country level. However, when we want to droop into the individuals, the agent-based model, only the agent-based model can be used. And for example, as we consider very high level, very quiet scale details, as the time goes, we know more and more about the COVID. For example, how the virus load grows within the body, within a host, and how the virus spread to others by contacts between hosts. And given a specific individual network, we consider to combine the virus growth and the contacts between hosts together. The basic ground of such a high resolution epidemic scenario is if an individual infected, the virus begins to grow in his body and infect normal cells and release more virus over time. This is the virus scale, and when a susceptible individual contacts another person, this virus can spread between them, perhaps by droplets, and then a new circle of the virus growth began in another body. And the viral load is directly can be linked to the infectiousness. And the agent-based system especially can perfect build different layers of the urban citizens in life, in school, and in household. And with combined these three things together, we can build a much skills, find much high resolution of epidemic scenarios from the virus to the body to our life in real life. And as a demo, we have used such an agent-based model just described to study the impact of influenza antiviral Block-severe on seasonal influenza, and observed, for example, this study just as a demo with that framework. You could say the observed incidence of influenza virus is red based on the US surveillance data in 2007 and in 2017 influenza season, and compared a typical modeling simulations without any antiviral treatment. It's in the black, and we can estimate what if 30% of cases receiving the Block-severe in the blue, or Australia in the green, different antivirals. We could estimate 22 million infections, and 6,000 deaths could be avoided if people, for example, people are infected by influenza, and 30% of these people can take the drug within 48 hours. And right now, we have applied this framework, working on COVID-19, and have finished the manuscript, and I think it will be online perhaps very soon. That's all. That's all my modeling for the top-down to the high resolution. And what's the questions of?
Great. Well, thank you so much, John Wade. That was great to see the different levels of modeling, from the meta population all the way to the agent-based model. And one thing that was clear is which one you choose, what level of modeling you choose really depends on what questions you want to answer and the level of detail you want. And there are also other choices in terms of how long it takes, how much data it needs, and all of that. So thank you so much for that introduction, John Wei. We'll hold on to question and answer until the end. I do request folks in the audience, if you have questions, please keep typing them into the chat box. We are collecting them as we go. Our next presenter is Nadia Siddiqui. Nadia is the Chief Health Equity Officer at the Texas Health Institute. She is working to advance health equity and making sure that it is an integral component across all of the Institute's processes and programs, as well as across Texas and the nation. Thank you so much for joining us, Nadia. Over to you.
Dr. Rai and team for having me here. It's a pleasure. And thank you all so much for joining as well. So I'm going to make an attempt to really ground today's discussion in equity and the importance of equity, particularly in COVID-19 response, recovery, and as we move forward to our rebuilding efforts here within our state of Texas. I'd like to start first and foremost, always like to start with a definition of health equity and what it means. It means that, to ensure that everyone has a fair and just opportunity to achieve their best possible health. And as we've seen with COVID-19, the impact has not been felt equally by all. Not everyone has been able to thrive through these times. And so it's really critical that we reckon with and come to terms with and really address our deep legacy and history of systemic racism and neglect, and really call to action centered in equity. And why now? What's different? What did COVID-19 really make us realize and wake us up to? The fact that no one is immune. People of color are being disproportionately affected, and they are essential to our society, and we have to make an effort to really respond appropriately. The fact that we're all interconnected, my health affects your health, and vice versa. The numbers, the sheer impact that this pandemic is having on people of color, those who have been historically marginalized. It's really important for us to take that into consideration. The fact that Texas is changing. Demographically, we are becoming more and more racially and ethnically diverse. And so our policies and our policy landscape must reflect that shift. And finally, the economics of it. We're all facing, at some level, have been affected economically from this pandemic. But again, that impact has not been felt equally. And those disparities have placed a price tag to society and our economy. And so, in September, we put out a report. I've got a link down here if you're interested, that really helped highlight the state of COVID-19 inequities within our state of Texas, discuss its root causes and drivers, and then provide a systems level approach and recommendations to really moving toward closing these gaps and achieving health equity. So I'll walk through some of our key takeaways that can hopefully provide some food for thought for today's discussion. The first is that racial and ethnic COVID-19 inequities are deep and they are widespread across our state. And those facing really the brunt of this pandemic have been our Hispanic and Black residents. You see here graphed data from DSHS where in particular the Hispanic community, but also Black African Americans in Texas facing higher proportion of cases and deaths as well. And this disproportionate impact is not confined, to any one area. We are all really across all communities seeing this disparate impact play out, whether we consider our urban cores or East Texas, where we have some of our rural communities, or El Paso. Across the board, people of color, in particular Hispanic and Black Texans, are facing the brunt of this pandemic. And these are some, CDC put out a new COVID data tracker, and so I pulled some data from there that are really powerful here to kind of hit the point home. What you see here are COVID-19 7-day case rates by percentage of county population that is Hispanic. That's the top chart, and the bottom one in poverty. This is for the state of Texas. And I want you to pay attention to those blue lines in particular in comparison to the orange lines. So the blue line on the top graph shows that, rates of cases are disproportionately higher among counties that have a larger Hispanic population. That was the case, in our previous major wave, and then now we're seeing the same thing occurring within this wave. And below, similarly, you see higher rates of cases in counties with higher rates of poverty. And these are the two charts that are really very telling compared to all other measures. CDC provides an opportunity to look at these data in a few different ways. And so really point to an opportunity for us to identify what are those systemic solutions that can help us really close these gaps and flatten the curve at the same time. The second takeaway from the report was that, the true magnitude of COVID-19 inequities is likely underestimated within our state for various reasons. Number one, as you may know, our cases data is very poor. There's only one other state reporting worse data than we do. Only 5% of the case data is available by race ethnicity within our state. And those data are reported inconsistently. As far as deaths go, we know that these deaths are being undercounted. And when we consider COVID-19 deaths, we also must adjust for age, because we know that there is a steep age gradient associated with COVID-19, and our age structures for white Texans and those of color are very different. Much larger, younger population among people of color compared to our white Texans, a larger proportion who are in the older age category at greater risk. But when we adjust for age, we actually find that Hispanics have 4 times and Blacks have 2 times the rate of COVID-19 deaths as white Texans. And that's what you see graphed here in this chart. The third key takeaway was the fact that it's not just the health and human toll of COVID-19 that's been disparately kind of distributed across our communities. We're also seeing that the economic fallout of COVID-19 is disproportionately affecting people of color, in particular Hispanic communities, and also Black Texans. And so these are the household pulse survey from the U.S. Census Bureau from phase 2. You'll see if we consider, as of mid-October, the share of adults in households facing food insufficiency on the left-hand side. On the right-hand side, you'll see households facing, difficulties with paying rent. In both cases, as of mid-October, Black and Hispanic residents in Texas have twice the rate of facing these economic barriers than their white Texan counterparts. And for those of us, and most of us really, this comes as no surprise. It is no accident that people of color and including low-income population groups are facing the brunt of this pandemic. This is because of systemic racism, systemic neglect, policies, discriminatory housing policies, lending policies, all kinds, even our healthcare coverage policies in many ways discriminate against those who have employment and have the opportunity to get coverage versus those that don't have employment and aren't covered. So we have a system based on, advantaging some over others. And that systemic neglect, systemic racism is really what's playing out amid this pandemic. And so what you see graphed here are data from the HOPE initiative, the Health Opportunity and Equity Initiative. We just rolled out our interactive data graphic actually a couple of weeks ago at hopeinitiative.org. It provides health outcomes, social determinants of health data for every state, the nation, by race, ethnicity, socioeconomic status. So what you see graphed here these are pre-pandemic data for Texas. And what we see is that COVID-19's unequal impact is a direct reflection of the circumstances these communities were facing well before the pandemic arrived. So we can look at home ownership, livable income, post-secondary education, the percentage of people living in low poverty neighborhoods, and across the board, if you look at the green and yellow dots, those facing the greatest barriers, even before the pandemic and over the years, are our Hispanic and Black communities in Texas. Likewise, when we consider healthcare measures, health insurance, access to primary care, having a dedicated provider, by and large, in particular, Hispanic Texans, but also Black African American Texans also facing huge barriers that then play out in risk for contracting the virus, experiencing severe illness or death once infected, and also facing adverse economic impacts. And so that was our takeaway 5. The very fact that, because of the systems we have in place, a large proportion of our essential workers, in many cases low paying wage workers, are people of color. And in metro areas such as El Paso, Houston, San Antonio, an even larger percentage, 77, 80, 89% of frontline workers are people of color. And so any policies really must address the importance of this essential workforce and the need to protect and safeguard the health. And those factors that I talked about previously as well are the driving force for higher chronic disease rates, and another reason why we see higher rates of severe illness among people of color. So what do we do about this? How do we move forward to developing more equitable policies? In our brief, we put out 5 key recommendations. Number 1, that we've really got to invest in systemic solutions. What we mean by that is we've got to really reckon with bad policies that exist in, housing, in our food systems, in, wages, employment, so forth, to where we're really providing everyone the opportunity to achieve their best potential. And so really making and investing in cross-sector solutions and centering them in equity. The second, around leadership and accountability. A lot of states that early on saw deep disparities by race, ethnicity, were quick to establish a state task force and strategy for advancing health equity and COVID-19 response and recovery. We have legislators since April who've been calling for such state leadership. We have not seen it. And so really this is an important factor to containing the virus here within our state. Data and transparency and the importance of standardized and data collection, reporting of disaggregated data by race, ethnicity, gender, other demographic factors, so that we can track and address disparities and importantly allocate resources, whether it's testing sites. We saw big challenges there when testing sites first came out. And now as we move into the vaccine distribution planning and allocation process, these data will be critical. The engagement of communities is central to this work. Across the board, we really must engage diverse communities and their trusted leaders, partners, to ensure a culturally, linguistically tailored and equitable approach. And then finally, none of this is possible without a financial commitment. And so we really have to put our money where our mouth is. We've all been talking about systemic racism and the importance of equity, but it's really time that our financial resources begin to align with systems change across sectors and taking a systems approach to closing gaps and achieving equity. So with that, I thank you for your time, and here's my contact information, and look forward to the robust discussion following the presentations. Thank you.
Great, thank you so much, Nadia. That was quite sobering. Thank you, and very insightful as well. Our next presenter is Dr. Kale Reeves. Kale is a postdoctoral researcher at the LBJ School, where he's also a lecturer. His research focuses on individual level decision-making processes and their subsequent outcomes. His areas of interest are primarily in energy, but over the last several months, he has been spending a lot of time and working with a number of folks at the LBJ School in building up an agent-based model. And so he'll share with us the results and insights from that. Over to you, Kale.
Okay, I think I've unmuted in video. Great, thanks for the introduction, and thanks also to Jean-Wei and Nadia for sort of setting up a conversation here. I was really interested in Jean-Wei's ideas about different questions that you can ask in different times. And the work that I'm going to share now sort of closes the feedback loop between the questions, what do we do about it, and what is the impact? So over the past several months, we've built this tool we're calling the COPE tool. It's a COVID-19 policy evaluation tool. And really what it is an example of a way that we can form expectations about outcomes, particularly about outcome equity. Let's see if I can, okay. So this sort of builds from this place of observing that there's a lot of variation in local policy designs, a lot of different ways to answer the what do we do about it question. Different states, different regions have all responded a little bit differently, but that coupled with an individual level behavioral response is really what generates these outcomes, both in terms of efficacy and equity. And efficacy is an important piece too, and we'll sort of break these down and separate them a bit. But just to give a sort of an overview of how our model works is we build some ideas about the way folks interact. As you saw in Jean-Wei's presentation, it's really this interaction that creates the opportunity for an exposure. So we have agents that are interacting in a social sphere and in a professional sphere. And that's meant to capture these ideas of having social interactions and also both going to work and providing an essential service and receiving essential services. So these are sort of some really policy relevant types of interactions that we're capturing in our model. And that's what generates these, again, opportunities for exposure. So we take this exposure generating piece and we overlay from the epidemiologists, Jean-Wei included, the idea of an epidemiological progression. So once we put people in this exposed place, we use this empirically grounded idea about what happens next to progress folks through the illness. They become asymptomatic, they become symptomatic, they recover, they're hospitalized, and some eventually become deceased as well. And that sets up one of these feedback loops where these individuals change the way they behave in the model based on their status. And we'll talk a little bit more about that later. Once we have those two modeling pieces, we overlay them on the underlying distribution of location, income, occupation, age, and race ethnicity that comes from the American Community Surveys data. This is where we really capture, as Nadia was saying, the systematic component of inequity that's built into the way folks get jobs, get income, where they live. And that allows us to have this systems-based approach, as Nadia was mentioning, to thinking about equity by thinking about how folks interact, how that causes them to become ill, and how that is related to their status in the system of a particular location. Once we have that idea built, this idea of how folks respond to their illness and respond to policies, we can start to think about the underlying drivers of the decision to, for example, comply with a shelter in place, to stop having interactions. And we relate that to risk tolerance. And this is what drives the behavioral responsiveness of agents in the model. Folks have a risk tolerance, which starts out based on some things that we observed about younger people engaging in more risky behavior. It starts out based on age, but then we allow agents to update their risk tolerance based on what they perceive in their social networks and on each interaction that they enter into. This is allowing us to capture things like folks looking around and noticing that people that they know are experiencing illness, and to say, that scares me, and to sort of decrease their risk tolerance based on what they perceive. It also captures things like when, for example, somebody enters into a interaction with other people who, let's say, have a lower risk tolerance than they do. And they change their behavior based on that perception of a social norm. Something like maybe pulling your mask back up above your nose when you look around and notice that everybody else is well masked. So by capturing these really dynamic components of individual behavior, we can change how the disease progresses amongst the agents in the system. And that really ties into the policy piece. This is the what do we do about it, right? So there are several different sort of classes of behavioral responses. For essential employees, these are folks who the shelter-in-place policy says you still need to go to work. If they are compliant with a shelter-in-place order, you'll see in this little red figure, I think you can see my mouse here, they'll stop with the social interactions, but they will continue to receive essential services and to provide essential services. If they are non-compliant with the shelter-in-place order, they'll do all of that and continue to have social interactions. For a non-essential employee, they have the same relationship vis-a-vis compliance, but they will stop being essential service providers because they're not declared essential. And then when folks get sick, as you see this person is, then they shut down everything. This is an acknowledgement that they are going to engage in behavior that protects others and quarantine, essentially. So now we have built this framework that allows us to have folks who interact with each other and change the way they interact with each other based on the status of themselves and others and policy within the system. Then we're able to look at some policy scenarios. I'm going to focus only on the timing for this talk, but that turns out to be a pretty important one. And by timing, I mean, when does a shelter-in-place policy go into effect? The baseline that we'll talk about is at the 28 days after the first infection. And then an early shelter-in-place order is a week earlier than that. And a late shelter-in-place order is a week later than that. And these, I should mention, this simulation that we're going to talk about is conducted entirely within Austin, Travis County. We're simulating about 500,000 households over 120 days with, high resolution. We're able to see a lot. And we can see the first insight that comes out of this approach to understanding policy response is that early timing is very effective for reducing peak hospitalization and total hospitalization. That's what you're seeing here. In orange is the percent hospitalized, and in blue, the sort of level of the peak. And it's much lower than the baseline, that black line, when shelter-in-place orders are issued early. Late shelter-in-place orders, on the other hand, generate much higher peak hospitalization and total hospitalization than the baseline. So the key insight here is that timing's pretty important, and it has a huge impact on the efficacy of the policy. But because we have all of these individual level characteristics that come from ACS, we can dig deeper than that. We can look, for example, at hospitalization over time. So the shelter-in-place order is this shadow that you see here. And in black, we see daily hospitalizations occur for daily hospitalizations, which we then break down by age, because keep in mind, we know the ages of each of these agents. And as you might expect, there is a sort of a pattern in the ages. Let's consider, for example, the 50 to 64-year-old group that you see here in green. They make up a certain proportion of the total population. That's that dotted green line that is flat. They occasionally experience more than that proportion of the hospitalization. That's when this solid green line goes above the dotted green line. This is a disequitably high proportion of hospitalization experienced by 50 to 64-year-olds, which is not surprising because we know that that is sort of baked in to the way this disease works. It impacts older people much more. But we know more than just the age about the agents in this model. So we can take a look at other things. We can take a look, for example, at income. And this is where it gets really interesting. An early shelter-in-place policy, which you recall was particularly effective, disproportionately burdens lowest income earners with more hospitalization. That's on the left, you see that large green spike above that line of proportionality. And it happens also in late timing. They also experience slightly less, but they also experience disproportionately more hospitalization. The key takeaway here is that we have a way, before you make a decision on what to do, to build expectations, not just about how effective the course of action is going to be, not just about the overall impact, but who it's going to impact, where and when. So just to sort of summarize on these takeaways points, this is an example of a tool that is able to form expectations about inequitable impacts. Highly effective outcomes can be inequitable. And the takeaway here from a policy perspective gets at what Nadia was saying. You need specifically tailored secondary policies to support these vulnerable communities. As Nadia was saying, folks are short on rent, short on food. We have every reason to be able to expect that, and we need to design policies in support.
Great. Thank you so much, Kale. We are a little tight on time, so we may not have too much time left for Q&A.